Good afternoon, everybody. This is Miriam Meisler speaking to you from Ann Arbor, Michigan. And it's my pleasure today to be able to talk to you on the topic of targeting SCN8A, or how can sodium channel SCN8A, encoding NAV1.6, contribute to treatment of Dravet syndrome. As you know, sodium channels are coded by a 10-gene family. We have SCN8A on chromosome 12. We have SCN1A on chromosome 2, and they share this conserved domain structure with the 4 transmembrane domains and cytoplasmic domains. And over here, I've just put the similarity between NAV1.1 and NAV1.6, which, if we look at the transmembrane segments, are 85% identical in amino acid level. If we look at the inactivation gate, they're 94% identical. And if we look at the first half of the C-terminal domain, they're 92% identical in amino acid sequence. So these are very, very closely related genes, but quite different, as you'll see, in their regulation. Now, both of these genes can give rise to very severe epileptic syndromes as a result of de novo mutations in the affected individuals. And here you see some of the representative patient mutations in SCN1A. More than 1,500 mutations have been identified in this 2,000 amino acid residue gene. By and large, they cause loss of function of the channel, and they occurred roughly at a measured incidence about 1 in 20,000. Now, here are some of the corresponding mutations in the SCN8A gene, where we have over 300 mutations identified. And in contrast to 1A, these mutations cause gain of function or excess function of the channels. And I estimate that the incidence of this disorder is about 1/4 to 1/5 of the incidence of SCN1A mutations. Now, SCN8A encephalopathy, or DEE, is extremely severe, more severe on the spectrum than Dravet. The average onset is by 4 months. It's refractory to treatment with developmental regression, and approximately half of the children with the severe mutations are wheelchair dependent. There's intellectual disability, ataxia, autism, and risk of SUDEP. So the first major difference between Dravet and SCN8A DEE is the effect of the mutations. As we said, the SCN, as you well know, the SCN1A mutations in Dravet cause a loss of channel function and reduced firing of neurons. In contrast, we have the reverse in the SCN8A variants. These mutations cause gain of channel function, by which we mean the channel has excess activity under physiological conditions, and this results in excess neuronal firing. The second major difference between these two genes is which neurons they seem to have a predominant role. And I think the most compelling evidence on this score comes from mouse mutants. For SCN1A, if you have a mouse model that only expresses these patient mutations in inhibitory neurons, this is sufficient to generate seizures. It's a failure of inhibition. Whereas if you make a mouse model and put these mutations into the excitatory neurons, you do not get seizures. In contrast with SCN8A, if you have a model expressing these DEE mutations only in excitatory neurons, this is sufficient to generate the seizure phenotype and lethality. Whereas if we put the same mutation in inhibitory neurons, we do not get seizures. So this explains why we have these contrasting effects. Normally, there's a balance in the nervous system between excitation and inhibitory circuits. If we lose SCN1A, we move into excess excitation. And if we gain excess activity of SCN8A, we have the same effect. So this explains the kind of adverse relationship between these two genes and this disorder. Now, this was our question. Can reduction of SCN8A compensate for deficiency of SCN1A by shifting this balance back to an even keel. And the way we went about asking this question was to reduce SCN8A expression using a specific ASO and then testing the effect in Dravet mice. So first, I'm going to show you the data on the 8A ASO in the 8A mutant mice that established that it was an effective reagent, and then show you what happened when we put the same ASO into the Dravet mice. And this work was reported about a year ago, and it's a collaboration between our lab at Michigan and my colleagues at Michigan and Ionis Pharmaceuticals. So the ASO that we're using is called a Gapmer, and the location that it binds is in the 3' UTR of the message. And by binding this Gapmer, we get a substrate for mRNA degradation by the enzyme ribonuclease H1. So here's the location of the binding, this 20-mer, and the ASO is called a Gapmer. It's composed of 5 nucleotides of RNA and then 10 DNA nucleotides and 5 RNA. And it's this hybridization between the DNA region of the Gapmer and the RNA transcript that generates a signal for degradation by ribonuclease H. So you can see that here. This is in vivo data. We are looking at the brains of wild-type mice, and we administered that ASO. We injected it into the intracerebroventricular space at P2, and then we watched the transcript level. So this is SCN8A mRNA starting at 100% of wild type, injection of 45 micrograms of ASO. Looking at 3 weeks, we're down to 50% remaining RNA. But as the weeks progress, this returns to normal. And by 6 weeks, we have the normal level of transcript. So that's very important to remember when we come to the Dravet syndrome data. Now, the mouse model that we're using has a patient mutation of SCN8A to test the effect of this ASO. And this mouse that we generated has 2 copies of exon 26. Without CRE, normally it expresses the wild type variant, but if we expose it to a CRE, depending on the specificity of the CRE, we rearrange this gene and we then express the W or the tryptophan allele. Now, this is what happens if we cross these mice with a CRE that's expressed throughout development. We get very early onset epilepsy and sudden death after the first seizure, in fact. So here you can see percent survival. The wild type mice are surviving for this 3-month period, but the mice that have the R1872W mutation of 8A, they have sudden death between 3 and 4 weeks of age, and they're all gone by 1 month. Now, as an aside, I think it's quite interesting that if we use a different CRE and we turn this mutation on only in the adults by giving tamoxifen at 2 months of age, we see the same phenomenon. We get seizures and death by 2 months later. But going back to the earlier format, this is mice that were treated at P2 with an ASO, and these are mice with the E2A CRE. And you see with the control ASO, they're dying, as I showed you a minute ago, between 2 and 3 weeks of age. However, if we inject increasing doses of this SCN8A ASO, we could prolong this survival for up to 7 weeks. And in fact, the survival, weeks of survival was directly related to the amount of ASO that was injected. So this is a good evidence that in fact, reducing the amount of this hyperexcitable channel solves the problem for these animals, and we don't get seizure onset until quite a bit later. We also demonstrated that a second administration of the ASO would further extend the seizure-free survival. So here we have our untreated mice dying between 2 and 3 weeks of age with the same, with the ASO given at P2, we're surviving for 5 or 6 weeks. But if we give another second injection right here, we can prolong this again. So we think we could keep doing this indefinitely. But the point is that unless we give a second injection, these mice do not survive. So they require the consistent downregulation of this hyperactive channel. Now, we showed that this reduction of 8A expression is therapeutic for SCN8A DEE. Is it possible that reduction of 8A expression would also be therapeutic for Dravet syndrome? And here we needed a mouse model of Dravet, and we used Jennifer Carney's model. This is an SCN1A allele with deletion of exon 1, and we studied it on the 129 black 6 F1 background. So start with what's the effect on the 8A transcript, and is there any effect on the 1A transcript, which would complicate interpretation? But the 3' UTRs of these transcripts are quite different. And here you can see that the 8A transcript is reduced to about 50% in 3 weeks, not only in the brain, but also throughout the spinal cord. And there's absolutely no effect on the SA1A transcript in the same animals. So this is what happened to survival. We give this one treatment with the 8A ASO, and the untreated mice have seizure onset at about 1 month, and approximately 50% of the mice are affected, and there's only 50% left by 1 or 2 months. However, the animals, the Dravet animals that received the single injection of the 8A ASO all survived, and they survived for 6 months and beyond. So in this case, a single injection was sufficient to rescue the mice completely. And we think that that is probably because the mice go through a very critical period at 3 to 4 weeks of age. And if we can get them through that threshold, then they are okay with only half a normal complement of 1A. And in fact, we did a lot of EEG monitoring in Jack Parent's lab, and we never saw any abnormal EEG patterns. Here are 4 different mice, and once they were tested when they were 6 months old already, and there was no evidence of any seizure activity in these ASO-treated animals. So it appears that a single dose of the SCN8A ASO prevented sudden death in the mouse model of DSE and prevented seizures as well. So what is the status of this SCN8A ASO? The current status is that this ASO is still in preclinical evaluation. We're still testing additional ASOs, and we need to do more toxicology prior to applying for FDA approval. And there are challenges in the use of this SCN8 Gapmer ASO, one being avoiding excessive loss of SCN8A activity. Even loss of 50% can result in a level of intellectual disability and ataxia. And the unknown whether one dose would be sufficient in the human disorder if administered after seizure onset. However, we hope that in the future, SCN8A ASO may be one of the alternatives available for Dravet treatment, along with the Tango ASO, the gene replacement, gene correction, and the targeted small molecules, all of which, as you well know, are coming along and changing the landscape for Dravet syndrome. Well, thank you very much. I'd like to acknowledge my collaborators, the people who are currently doing this work in my laboratory, my recent postdocs, and my wonderful collaborators at the University of Michigan, and Frank Rigo and Payman at Ionis. So thank you very much for your attention.